Hello, I'm Dr. Isaac Tawil, and welcome to this brain death evaluation tutorial. After reviewing the following tutorial, you should understand when to involve the expertise of our organ procurement organization, New Mexico Donor Services, the difference between brain death and severe brain damage, all components of the clinical brain death evaluation, including how to properly check for brainstem reflexes and how to perform an apnea test, unique circumstances where the clinical exam cannot be completed and additional confirmatory tests must be performed, and lastly, we will review the process of organ donation after cardiac death, or DCD donation. First, a bit of background. In the United States, the principle that death can be diagnosed by neurological criteria, designated as brain death, is the basis of the Uniform Determination of Death Act, although the law does not define any specifics of the clinical diagnosis. This states that an individual who has sustained either irreversible cessation of circulatory and respiratory function or irreversible cessation of all functions of the entire brain, including the brainstem, is dead. The following information is consistent with the practice parameters of the American Academy of Neurology and the most updated versions of the University of New Mexico Hospital protocols for the determination of brain death and the UNMH policy on organ and tissue donation. Brain death is defined as the irreversible cessation of all functions of the entire brain, including the brainstem. There is a clear difference between severe brain damage and brain death. The physician must understand this difference because brain death means that life support is useless, and brain death is a principal requisite for the donation of organs for transplantation. One common misconception is that the organ procurement organization should be notified once brain death is determined. Actually, New Mexico Donor Services should be contacted way before this point. The clinical triggers for referral should be made to New Mexico Donor Services for any patient who meets any one of the following criteria: a patient placed on a ventilator due to neurologic injury, a patient with a Glasgow coma score of 5 or less, prior to brain death exam or apnea test consideration, prior to the discussion of removal of life support measures or withdrawal of care, prior to do not resuscitate or do not intubate discussion, a family member who is inquiring about donation. It is important to understand that referral to New Mexico Donor Services is required even when the patient's suitability is in question and/or the legal decision maker is not available. Now that we have already contacted Donor Services, we are going to review the clinical examination for brain death determination. First, we must establish that the patient in fact has a clinical or neuroimaging picture of an acute cerebral catastrophe that is compatible with the diagnosis of brain death. Further, we need to exclude complicating medical conditions that can blunt brainstem reflexes and give the false impression of brain death. So, prior to embarking on brain death testing, we must first exclude and correct any severe acid-base disturbances, any electrolyte disorders, or severe hemodynamic derangements that might confound the exam. Additionally, severe hypothermia and intoxicating substances or administered medications may blunt brainstem reflexes. Brain death testing is not to be performed until these confounders are excluded or corrected. Once you've established that there is evidence of a cerebral catastrophe and have ruled out any possible confounders that could masquerade as brain death, you can then move on to assessing the 3 cardinal findings of brain death. Number 1, coma or unresponsiveness. Number 2, the absence of brainstem reflexes. And number 3, a positive apnea test as defined by no respiratory response to hypercapnia. We have established the prerequisites to allow for further testing of brainstem reflexes. First, we can appreciate that the patient is not initiating any spontaneous breathing. Then, we go on to confirm cardinal finding number 1, unresponsiveness, by demonstrating an absence of the response to noxious stimuli. We can do this by demonstrating no response to nail bed pressure. One can also test for a response to pressure on the supraorbital nerve. If no response is observed, then we move on to testing cardinal finding number 2, which is testing for brainstem reflexes. Let us now go through the brainstem evaluation. First, we test cranial nerves 2 and 3, which is the pupillary light reflex. Simply shine a light in the eyes and check for pupillary constriction. If no pupillary response, this brainstem reflex is absent. Next, we will test the corneal reflex, which tests cranial nerves 5 and 7. Simply apply gentle stimulus to the cornea and watch for any eyelid contraction. This may be very subtle, but in its absence confirms dysfunction of cranial nerves 5 and 7, which originate in the brainstem. Next, we will evaluate cranial nerves 9 and 10, which are responsible for the cough and gag reflex. We manipulate the endotracheal tube to stimulate the vocal cords and watch closely for a cough or a gag. We also check this reflex by inserting a suction catheter down the endotracheal tube and watching for a similar response, either a cough or a gag. The absence of a cough or a gag indicates absent function of cranial nerves 9 and 10. Next, we check the oculocephalic reflex, or the doll's eyes reflex, which evaluate cranial nerves 3, 6, and 8. Note, the patient should not have any question of a cervical spine injury before performing this test. With the patient's eyes opened, we turn the head to both sides and watch their eyes closely. This reflex is maintained if the eyes stay focused on the midline, but absent and consistent with brain death if the eyes follow the head movement. The last cranial nerve test, which also evaluates cranial nerves 3, 6, and 8, the vestibulo-ocular reflex, is tested using cold calorics. After checking for patent tympanic membranes, we instill ice water into each auditory canal while closely watching the patient's eyes. This cranial nerve reflex is maintained if there are rapid syndicate eye movements toward the direction of the stimulus and followed by slow movements away from the stimulus. This reflex is absent and consistent with brain death if there are no eye movements. Now that we have confirmed the absence of all brainstem reflexes, we can move on to the third cardinal finding, a confirmatory apnea test. During the apnea test, we are checking for a respiratory response to a hypercapnic stimulus. Note, we must first ensure that the patient is hemodynamically stable and so will not deteriorate after being disconnected from the ventilator for this test. Disconnecting the patient from the ventilator for the apnea test may endanger the patient if they are requiring high mean airway pressures to maintain oxygenation. Evaluate the appropriateness of performing this test on a case-by-case basis. Likewise, if hypoxia or hemodynamic instability occurs during the test, it should be aborted immediately. Then, we must have everything prepared, including several arterial blood gas syringes. Further, this test must be performed in collaboration with the bedside nurse and the respiratory therapist. First, we draw an arterial blood gas to ensure that the patient's PCO2 is within their normal limits. We then disconnect the patient from the ventilator and introduce supplemental oxygen via a nasal cannula placed through the endotracheal tube, sitting at the carina. We watch closely and continuously for the chest to rise as an indicator of an intact respiratory drive. If the patient initiates any respiratory effort, brain death is ruled out. We check another arterial blood gas sample at 5 and 10 minutes to assure that the patient's PCO2 rises to 60 or 20 above the patient's baseline. For example, a carbon dioxide retainer may begin the exam at a PCO2 of 50 and then must increase their level to a PCO2 of 70. If during the entire exam there is no attempt at spontaneous respiration after the PCO2 increases appropriately, this is consistent with brain death. Neurological states that may mimic brain death. It is of primary importance to be aware of common mimickers of brain death. Again, conditions including severe hypothermia, drug intoxication, profound hemodynamic derangements, and neurologic dysfunction including locked-in syndrome or Guillain-Barré syndrome involving all cranial nerves and peripheral nerves may appear as brainstem death. All of these confounders must be ruled out or corrected. Let's take a minute to discuss common difficult situations during brain death testing. Severe facial trauma may make cranial nerve testing difficult or simply impossible. For example, testing oculocephalics, the doll's eyes reflex, is contraindicated if a cervical spine injury is suspected. Clotted blood or cerumen in the auditory canal may influence the response to cold calorics. A high cervical spine injury may make apnea testing impossible. And lastly, the patient may be hemodynamically unstable or have significant lung injury, making apnea testing impossible. When any of these situations makes it difficult or impossible to complete the entire clinical brain death evaluation, a confirmatory study evaluating cerebral blood flow or activity must be done. Confirmatory tests include cerebral angiography, nuclear imaging studies, CT angiography, magnetic resonance angiography, and EEG monitoring. What test is chosen is based on your individual institutional guidelines and the treating attending physician. Another phenomena that one might encounter in the setting of brain death is that of spinal cord-initiated reflexes. Spontaneous body movements may be observed at any point during brain death testing. They occasionally may be difficult to discern from respiratory effort. Often, these are movements generated from the spine and should not be misinterpreted as brainstem function. Evidence of brain death comes from a consistent clinical exam and confirmatory imaging. There is some procedural variation regarding brain death testing from institution to institution. At the University of New Mexico, the policy requires that 2 separate clinical exams be performed at least 1 hour apart by 2 different physicians. Both physicians must agree that apnea test results and any confirmatory tests are consistent with brain death before pronouncement can occur. Both examiners must document the results of clinical exams and testing in the medical record. Again, only 1 apnea test is required. There are also some procedural differences in the pediatric and neonatal populations. Vital sign normals must be age adjusted. The observation period between clinical exams also vary depending on the age of the patient. Please refer to the University of New Mexico protocol for this delineation. Donation after cardiac death. Lastly, we must remember that while brain-dead donors are responsible for most of the organs procured for recipients in need, organs donated after a patient succumbs to a cardiac death are an important source for organs for patients on transplant waiting lists. Patients who may be medically suitable as donors but do not meet brain death criteria may be considered for donation after cardiac death. Contact New Mexico Donor Services when considering that patient survival is unlikely, even if not progressing towards brain death. Please refer to the institutional protocols regarding donation after cardiac death. I hope this review has answered any questions you may have had related to the brain death evaluation process. For any others, you may refer to either the University of New Mexico institutional protocols or the practice parameters published by the American Academy of Neurology. Thank you.